Hello and welcome back to Unacademy. So let's crack NEET PG. Myself, Dr. Muskan Chaudhary, and I will be guiding you through NEET PG Microbiology. So start starting my session. So as we know that an academy provides us a daily life class in which the educator and aspirant can chat, can engage in the discussion, can aspirants can ask their doubts and do the answer polling, and that is all that is going within the live class. Along with the live test and the quizzes, that is another great feature of the academy, and along with the unlimited access in which specifically those students who are very free and are the medical officer and preparing for the examination can actually watch the recorded live sessions recorded, because sometimes it does happen that during duty sessions they are not able to watch the live session, right? And the structured course is something that is provided by almost all the educators, and one or two structured course is now given by almost every educator for every subject, in which the revision courses are done and the high yield topics are taught, right? Just a second. So one is the icon subscriptions, in which the Prep Ladder and the Unacademy has collaborated together. Now, in which the rapid revision courses of the Prep Ladder, as we know that is it's among the one of the most famous for the aspirants. That is rapid revision courses and the video lectures of the Prep Ladder. Now, uh, to in the icon subscriptions, you along with the Prep Ladder, you get the perks of the Unacademy and the Prep Ladder of the top both the topmost education platform. Now, coming to the professional 3-year batch course, something that is being provided, and in which the doubt clarification with the live interactive classes and the clinical and intricate approach is something that is has been done. Now, FMG batches is being initiated by the Unacademy for the 6 months duration, and the PDF notes are given along with this. And one of the greatest advantage is that if you get the 12-month subscriptions, you get 2 month subscription totally free, right? And do use my code, that is Muskan 10, to get the 10% of the discount on the NEET pitch subscriptions. Now I will recommend you to have at least 1 to 2 subscriptions, and mainly for those students who are in the medical college and preparing for the NEET PG for 2 to 3 years, something that is needed, and compared to the other courses that is present online on all the other platforms, Unacademy is one of the reliable and the economical, and the perks that we are getting from the Unacademy is nothing that is being provided by any other online platform, right? So Bugs Bounty is something that is new, in which any aspirants who if found any something that is error with the slides or the content of any educator, then let us know, and you will win the exciting prizes and the offers, right? Now, starting with the first questions, all of the following are the dimorphic fungi except. Okay, so all of the following are the dimorphic fungi, except now we will covering the mostly questions. Theory will be covered very less because it is random questions and exam is over the head. So I have just taken down the question answer session only. Right now, Sporotrichium, Blastomycetes, and the histoplasma. Now we remembered a mnemonic for the dimorphic fungi, and obviously Cryptococcus is not a dimorphic fungi. Now we have to remember what is the dimorphic fungi. They are the fungi that can reproduce either a mycelial or the yeast form, right? And they are generally yeast producing at the 37 degrees Celsius, and the vegetative form at the 25 degrees Celsius, right? The dimorphism is important in the identification of the mycosis, and the mnemonic that we read for the dimorphic fungi is HPPSC, that is histoplasma blastomycosis, paracoccidiomycosis, portrix, and the coccidiomycosis. Now, dimorphic fungi examples are very important, and direct questions are again asked in the examination. Now, blastomycetes, this is the figure of 8 appearance that is present in the blastomycetes yeast form, and we have to remember this. Now, blastomycetes is also called as the North American disease or the Piltridge's disease, and the figure of 8 spore now is important to remember the this image is important for the blastomycetes at a figure of 8. Now, not true about the histoplasma capsulatum is that it is a okay, so just 10 seconds for the question. So, not true about the histoplasma capsulatum. Okay, so histoplasma capsulatum is dimorphic fungi. It's true. It may mimic the TB. It is also true. It is capsulated or mostly asymptomatic. So it is mostly asymptomatic, and histoplasma capsulatum is not capsulated. It is the cryptococcus neoforms that is capsulated, and we have to remember this, that cryptococcus is capsulated, right? So now coming to the histoplasma capsulatum, now histoplasmosis is also known as the Darling's disease, and the disease manifestation occurs after the inhalation of the spores, and the mainly manifestations are pulmonary manifestations. Right. So capsulated histoplasma capsulatum, sorry, this they are not capsulated. So this option is false, right? So they are what? They are non-capsulated, and the only medically important capsulated fungus is Cryptococcus. Infection is acquired by the inhalation of the microconidia in dust contaminated with the bird or the bad dropping, right? It causes the intracellular infection of the reticuloendothelial system, and the majority of the patients, they are what? They are asymptomatic. Right. So fungal examples that are intracellular, one is the histoplasma capsulatum and another is the cryptococcus. Remember, cryptococcus is what? It is capsulated. Now, histoplasma capsulatum showing the intracellular form within the macrophage. Moving to the next question, an early diabetic has left-sided orbital cellulitis. CT scan of the paranasal sinus show the evidence of the left maxillary sinusitis. Right? Gram stain smear of the orbital exudate shows irregularly branching septate hypha. The following is most likely etiological agent, that is either Aspergillus, Rhizopus, Mucor, or Candida. So the key points we have to check out in the question, one is the diabetic, and we are talking about the orbital cellulitis and the maxillary sinusitis. Okay, so the answer is what? The answer is the Aspergillus. Now we get now one is the diabetic, so we may get confused between the Aspergillus and the Candida क्योंकि दोनों opportunistic होते हैं. But remember that the another point, important point that is given here is what the orbital cellulitis and the maxillary sinusitis, because the clinical manifestation of Aspergillus is the paranasal sinusitis is amongst other one of the manifestation, and the most common site of the spread of aspergillosis is brain. Right, treatment drug of choice is surgical removal and the voriconazole. and it caused the invasive pulmonary aspergillosis. Okay. Now, what are the most common risk factor for the aspergillosis is very important in neutropenia on the glucocorticoid therapy, and most common is aspergillus fumigatus, that is responsible. It is the most common aspergillus that is causing the aspergillosis, right? So most common site to spread is the brain, and the surgical removal along with the voriconazole is the drug of the choice, and it causes the invasive pulmonary aspergillosis. And the risk factors are the patient diabetic and the neutropenia and the clinical manifestation paranasal sinusitis. Now, presence of the branch septate hypha in a patient of orbitocellulitis, such as the aspergillus. Now, ball of hypha may form in chronically obstructed paranasal sinus without tissue invasion. Chronic fibrosing granulomatous inflammation begin in sinus and slowly spread to the orbit and the brain. Right? Allergic fungal sinusitis, mucor and rhizopores belong to zygomycetes and have the non-septate hypha. So we also should have the clearance of the septate and the non-septate hypha, since aspergillus is what the branch septate hypha and the other two are the non-septate. Now moving to the sclerotic body is seen in sporothrix, blastomycosis, chromoblastomycosis or coccidioids. तो व्हाट इज द आंसर? स्क्लेरोटिक बॉडी को अपन मेडुलर बॉडीज भी कहते हैं, इनको अपन कॉपर पेनी बॉडीज भी बोलते हैं ड्यू टू अपीयरेंस दैट इज अ कॉपर ब्राउन, और अपन को कहाँ मिलते हैं? क्रोमोब्लास्टोमाइकोसिस, राइट? नाउ if you see, these are the sclerotic body or the copper penny body or the medullary bodies. It is an important image. Now another option was the sporotrichosis or the rose gardener's disease, that is mainly acquired by the after the trauma and after picking up in the garden or picking the rose in the garden, that it is acquired after the trauma. And the starts with a thorn pick and gets into the lymphatic system, and it is this is the cigar shaped asteroid body of sporothrix. Okay, and the clinical presentation is along the lymph nodes, lymphatic channel, that we have to remember. This is the classical presentation of the sporothrix, and this is what this is. I told you this is the figure of 8 appearance seen in where blastomycosis or North American disease or the Gilchrist disease. Right now, 1,3-beta D glucan assay for fungi is not used for Aspergillus species or the Candida species, Cryptococcus species, or Pneumocystis cerevisiae. Right. So, what is the correct? ठीक है, पहले तो पता होना चाहिए कि अपन किसकी बात कर रहे हैं. अपन 1,3-beta D glucan ऐसे की बात करें. ये क्या होता है कि it is present in the cell wall of the fungi, but there are some exceptions to it as well. So one of that exception is the Cryptococcus species, and this is simply a mug-up question. We have to remember this. कि 1,3-D glucan assay is the component of the fungal cell wall. But what is the exceptions that we have to remember? The exception one is the Cryptococcus. Another is the zygomycetes, and another example was blastomyces dermatitis, ठीक है, which is detectable in case of the invasive infection. Currently, fungital assay is FDA approved, and 1,3-D glucon assay, which is positive invasive candidiasis, Aspergillum, and pneumocystis cerevisiae. Now, false positive reaction may be seen with certain filters and beta-lactam entry microbials and immunoglobulin, but just remember the example that it is present in the cell wall of the fungi, but exceptions are the Cryptococcus, Zygomycetes, and the blastomyces, right? That is the BCZ. Uh, Now, coming to the next question, all are including the diagnostic criteria for the Clostridium difficile infection except three uniform stools for 24 hours for 2 days, toxin A and B in stool, pseudomembrane in colonoscopy, or fever. So, what will be the correct answer for this? So all are including the diagnostic criteria for Clostridium difficile. We know the pseudomembrane anticipated by the colonoscopy. This is true. Three uniform stool samples, three stool samples. Every 24 hours for 2 days we take and we check for the toxin A and B in the stool. Right, so ELISA that detects the toxin A and B in the stool is highly sensitive and specific, and the diagnosis is based on the three main points. That is, one is the diarrhea, that is the three uniformed stools for 24 hours for 22 days with no other recognized cause, plus toxin A and B in the stool. So one is the uniform stool sample and the toxin A and B in the stool, toxin producing detected in the stool by the PCR or the culture, and the pseudomembrane in the colon. Also, now that endoscopy is a rapid diagnostics tool in seriously suspected patient. A negative test does not rule out the infection. So, what are the three diagnostic criteria for the Clostridium difficile infection? That is, one is the diarrhea, another is the toxin, and the pseudomembrane. Now, coming to the vectors, now tick is a vector for it is more than one option is correct in this one, which is Crimean Congo fever, Rocky Mountain spotted fever, epidemic typhus, endemic typhus, or the scrub typhus. So, tick is a vector for. Okay, so tick is a vector for Congo fever and the Rocky Mountain spotted fever. Now we have to know the vectors because they are important. We'll come to the list. Now, Congo fever and Rocky Mountain spotted fever. Congo fever is a viral illness caused by the flavivirus and is transmitted by the ticks. Now, Rocky Mountain spotted fever is heart tick-borne fever, can also forest disease, and it is a febrile disease associated with the hemorrhage caused by the arbovirus, flavivirus, and transmitted by the bite of the infective hard ticks. Right. So we'll come to the this factors. Now remembered by the mnemonic, that is left fan try PSM, let fan try PSM, that is the let, that is the louse is the vector for endemic typhus, flea is the vector for this louse is the vector for epidemic typhus, flea is the vector for endemic typhus, tick is the vector for Rocky Mountain spotted fever, and the mite is the vector for the pox, rickettsial pox, and the scrub typhus. So let fen try PSM, that is louse, epidemic, fen, endemic, tick, that is the Rocky Mountain, and the mite, that is the scrub, and the pox, rickettsial pox. Now this is the vector that we have just read, that is the epidemic typhus, that is was the what was the vector, it was the let. Just now we saw it was the this Laos. Okay. Now for the endemic Rocky Mountain, for the Brilzinzers, it is also Laos. For the endemic, it was the rat flea. Now coming to the next question, disinfectant used for the blood spills, that is phenol, glutaraldehyde, ethanol, or the sodium hypochlorite. Now, each of these options that we are seeing, they have particular functions that use, although they all have the disinfection action, but they are particularly used for some specific. Now, for the blood spills, what we use what? We use sodium hypochlorite, right? Now, we'll come to the first we'll come to what? High level disinfectant. Okay. Now, high level, we read there that disinfectant, although are not able to kill the spores, but when we use the concentration in high amount, they are able to kill the spores. So high level disinfectant are capable of killing the bacterial spores when used in sufficient concentration. This was important point. So first we come to the aldehyde, in which we'll see the glutaraldehyde. And glutaraldehyde, one we saw that it was glutaraldehyde and the paracetic acid that was active even in the presence of what? Organic matter, right? So glutaraldehyde is what? It is the most common high level disinfectant used for the endoscopes and cystoscopes. This is very important point, that specifically glutaraldehyde is used for what? The endoscopes and the cystoscopes, and it is used in 2% concentration or 2.4. Just remember, 2% concentration Sidex or the glutaraldehyde is used for the endoscope or the cystoscope, right? It is available and has to be activated by the alkalization, and it is also used for the fogging or the cleaning of the floor and surfaces. But the most important point, that 2% concentration, this factory name is Cytex, and it is used for what? It is used for the endoscope or cystoscope. ठीक है, and activated by the alkalization. Now, what is the advantage is that it remains active even in the presence of what? Organic matter. Next disadvantage, it has bad odor, pungent odor, and can produce the eye irritation and the contact dermatitis. Orthophthaldehyde, we were using it also, it is similar to that of, but it has many advantage. That one is that just like glutathione does not require the activation, order is better, irritation is less, and it acts faster. Now, next is the formaldehyde, or it is similar to that of the glutathione high level disinfectant, but it is limited because of high irritation and the pungent odor, right? And one major drawback, it does the corrosion of metals, and it is potential carcinogenic. Therefore, it has been limited and restricted only to non-patient care areas, that is preservation of the anatomical specimens and the stool specimens. Now, it is also used for the fumigation, such as operation theatre, just like glutaraldehyde. Formaldehyde is also used for the fumigation, but the nowadays for the it has been limited due to the potential carcinogenicity. Now, next is the paracetic acid. Now, parasitic acid, it is used in automated machines, and it is used in combination with the hydrogen peroxide for the disinfecting hemodialysers. Now, H2O2, this is also high level disinfectant, and it produces H2O2 works by producing the free radicals. Now, it is porocidal only at 4 to 5. The concentration is, remember that it is porocidal at 4 to 5% concentration, and 3% for fogging we use, and the surface disinfection, right? And 6 to 7.5%, that is plasma sterilization. We are using sterilium plasma sterilization. Advantage that it is non-toxic, and similar to glutaraldehyde, it is active in the presence of the organic matter. Disadvantage that it's expensive and does cause the chemical irritation. So this was about the high level disinfectant. Now coming to the intermediate, first will the phenol, and we'll read about it, alcohol. Now alcohol and isopropyl alcohol, they are the most popular that is used action. They are bactericidal, but they are not capable of removing the spores because they are intermediate level. And as we do the dilution, as we dilute the concentration, the cytal activity rapidly drops, right? So alcohol is used for various purposes. Alcohol-based hand drops we are using sterilium, and in the small medical item for disinfectant of the rubber stoppers we are using, and disinfection of the external surfaces such as stethoscope, ventilators. We are using non-critical surfaces. We are using like medication preparation areas and the spirit. Now disadvantage is that because since it is alcohol, it is what flammable, it evaporates rapidly and inactivated by the organic matter. Now phenol is what the carbolic acid, right? And the father of the antiseptic surgery used the carbolic acid for the and so the post-operative infections were greatly reduced. And who was the father of the antiseptic surgery? It was Joseph Lister, right? And phenolics are what they are, protoplasmic poison. That is, they are taken, they disrupt the cell wall and precipitate the cell proteins, and used as a disinfectant. That is, Cresol and the Lysol. We have to remember this. Cresol and the Lysol, they are the common phenols that we are using. They are toxic to skin, so they are not used as antiseptics. They are, but certain phenols still are used antiseptics, and the example is what? Dettol, which are having the chloroxinol, right? So we have to remember this one point. One is that Cresol and the Lysols we are using in the phenols, and in the Dettol we are using the chloroxinol. Now, advantage is that they retain activity even in the presence of the organic matter. So, phenol, glutaraldehyde, and the H2O2, they were retaining the activity even in the presence of the organic matter. This is important to remember, right? Hmm. Disadvantage is that they cause the hypobilirubinemia in infants and therefore should not be used in nurseries. Coming to the one important, that is the halogen, that is the iodine and the chlorine we mostly use, right? So first we'll study about the iodine. What they will, most of the disinfectants, what they do, they disrupt the proteins and the nucleic acid is how they work. So that is one we'll read is the tincture of iodine, and the next we'll read about the iodophore or the povidone iodine. Now tincture of iodine is iodine 2% in the potassium iodine. Tincture of iodine, that is iodine in the potassium iodide, and it is antiseptic for the wound cleaning. Now, povidone iodine, we know it is prepared by the complexing iodine with carrier, that is povidone iodine, which helps in sustained release of the iodine, right? So it is why it is preferred povidone iodine that we mostly use in day-to-day life, because it is not staining and it is free of the skin toxicity. And what is the brand name? That is the Vescodine and the Betadine. Now, iodophores are both used antiseptic and disinfectant. Therefore, antiseptic iodophores are not suitable for disinfectants, and vice versa. Now, antiseptics that we are using as antiseptic in the concentration for the iodine is what? 1%, 5%, 7.5%, and the 10%. If we are using in the 1%, we are using orally for the oral wash, mouthwash. For the 5%, we are using for the wound cleaning. 7.5% we are using for the hand scrubs, and the 10% we are using for surgical skin preparation, right? So highest for the surgical, obviously 10%, lowest we are using for the mouth cleansing, and the 5% we are using for the in the povidone iodine for the wound cleaning, and 7.5% for the hand scrubs. Now coming to the chlorine and the hypochlorite. Now chlorine is one of the most commonly available preparation. One is the free chlorine. Another is the hypochlorite. That was our question about sodium hypochlorite. It is either in the liquid form or in the powder form. है, और लिक्विड फॉर्म में है तो सोडियम हाइपोक्लोराइट, एंड पाउडर फॉर्म में है तो कैल्शियम हाइपोक्लोराइट और ब्लीचिंग पाउडर. Yeah. Other forms are also present includes any disease, that is sodium dichloroisocyanurate, right? So we have to remember two forms are present. One is the liquid form and the powder form. Powder is with the calcium and the liquid form is with the sodium hypochlorite. Now, flea chlorine is used for the disinfection of municipal water supply, swimming pool, and the sodium hypochlorite important. It is available in the concentration of 5.25 to 6.15, and it is this is important that sodium hypochlorite in the concentration of 0.5% is used for large blood spills. In the concentration 0.05 is used for small blood spills. Okay, and if for the surface disinfection also we are using 0.5%. So 0.5% for the surface disinfection, right? And for the treatment of the liquid waste before disposal 1%, and the laundry item point. Remember 0.5% for the surface disinfection and 0.5% for the large blood spills. Right? Advantage is that it is broad spectrum, rapid in action, and non-inflammable, low cost, and widely available. Disadvantage, it also get inactivated by the organic matter, toxic to the skin, and daily preparation is unstable because hypochlorite is unstable and therefore easily evaporates, corrosive, and the leaves residue, offensive odor, and bleaches the carpets. Right? Now, comes the next question. Microbiological test for diagnosing the Leptospira infection is cold agglutination test, standard agglutination test, microscopic agglutination test, or none of these. What will the answer? So it is what? Microscopic agglutination test, right? Yeah, so it is what? It is microscopic agglutination test, right? That is the dark field microscopy or the by immunofluorescence or light microscopy after appropriate staining using microscopic agglutination test. Also, microscopic differential test is used for the leptospirosis. That is for we are using for the leptospirosis. Remember, for the leptospirosis, we are using what? We are using the MAT. Now, biofilm forming bacteria causes antimicrobial resistance by all of the following except the mechanical barrier, increased excretion of the antibodies, altered mechanism, or the adherence. So, what is the criteria by which biofilm is acting? So, we have to check the falsehood. So it is not by the adherence. Why? Because biofilm is formed when the number of bacteria they unite together and form a protective layer, right? So this leads to microbial resistance. That is, they act as the barrier. Very obvious. That is, they are acting as a barrier, and they increase the release excretion of the antibiotics and altered metabolism inside the biofilms. Now, growth in the biofilms leads to altered microbial metabolism and production of the extracellular virulence factors and decrease susceptibility to biocides and host defense molecules and the cells, right? Pseudomonas aeruginosa growing on the bronchial mucosa during chronic infection, staphylococcus and the other pathogens growing in implanted medical device. So one is the Pseudomonas aeruginosa, staphylococcus, right? So they are the biofilm forming. Now, as you can see, these are the bacteria, and bacteria are now aggregate together and form irreversible form a layer around themselves. That is the biofilm. And now we know that the how the biofilm was produced because in the bacterial general bacteriology that it is the layer of the glycocalyx around the bacteria. Now, coming to the next question, that is the buff, tough, and the rough colonies are seen on a growth media as shown in the photograph below. Is shown by, okay, so I missed to put the image here, but guess it by the question that buff, rough, and the tough colonies. That is shown by convective diphtheria, Mycobacterium leprae, tuberculosis, and the Leptospira interrogans. So, what is it? This is very easy question. So, what is it? It is Mycobacterium tuberculosis, right? So, rough, puff, and the tough colonies are shown by the Mycobacterium tuberculosis, and this is what? This is the Lowenstein Hansen's medium, and it is used to see the colony formation by the mycobacterium. As you can see, these are the rough, tough, and the buff colonies. Now, the Mycobacterium leprae, they form the smooth colonies, and this is what the algae media. Why the color is green? Due to malachite. Question that why the color is green? Due to malachite green. For the convective diphtheria, we don't use the algae media. We use the potassium telluride agar media. That is, by the reduction of the potassium tellurium, black colored colonies are formed, and this is how it is a selective in the differential media. The black colored colonies are formed, and we use it for the convective bacteria. What is the largest intestinal protozoa that is found in the human? That is the Entamoeba coli, Bacteria coli, Giardia lamilia, or the Toxoplasma gondii, right? So we are asked about the large intestine, not the small intestine, right? So this is what. So this is what. This is the Bacteria coli, right? Because Bacteria coli is the only selected protozoa that causes the human disease, and it is the largest of the human intestinal protozoa. Okay, and another is that now domestic animals, specifically pigs, are the main reservoir, and humans are the infected after ingesting the cyst in the food, right? And water contaminated with the animal and the human feces. So the cyst is the infective form, and the trophozoa exists in the small intestine, travels to the colon, and burrows into the wall, causes similar to that of the ant amoeba histolytica, right? So extraintestinal lesion doesn't occur similar to the ant amoeba histolytica, and the most cases are asymptomatic. Diagnosis is by the V-shaped nucleus that is seen in the cyst or the trophozoite form in the stool. So what is that is due to the V-shaped nucleus by the Bacteria coli, either trophozoite and the large cyst. The treatment of the choice is what tetracycline. Right, prevention consists of avoiding contamination of the food and the water. So one is the treatment of choice is the tetracycline, and the V-shaped nucleus is the characteristic. Cyst is the infective form. Now, this is what happens that the cyst is the infectious form that is present in the food and is acquired through the ingestion of the contaminated food. The cyst is uptake by the person, and the cyst now mature into the trophozoite form in the small intestine, and the trophozoite now they burrows now cyst and is shed in the stools, and both the cyst and trophozoite will be shed in the stools, right? So now, moving next to the following is true with the Giardia lamilia, that is, malabsorption is commonly seen, and the trophozoite form is binucleate. Diarrhea is seen both the B and the C. So, what is true? Okay, so malabsorption is not commonly seen with the Giardia lamilia, and neither the diarrhea because it is mainly asymptomatic. So and the trophozoite form is binucleate, right? So malabsorption is seen only in the few cases. Mostly patients are asymptomatic, and the most common presentation is diarrhea with the abdominal pain, nausea, and the vomiting. Trophozoite, we'll see the trophozoite is what? Trophozoite is the bilateral symmetrical. All the organs are equally paired with the two exostyles and the four pairs of the flagella. The gold standard for the diagnosis of giardiasis is the microscopic demonstration of the trophozoite and the cyst form in the feces. Diurnal aspirate or the biopsy of jejunum may be required. Now, metronidazole and the tinidazole are the drug of the choice. So this is what? This is the giardia with binucleate, right? And the two anterior flagella, two posterior flagella, and ventral flagella. Come to the next question. What is the false regarding the Mycobacterium? Right? That is the cell wall has high lipid content. Mycolic acid in allium form vexicot, and the lack exotoxin or endotoxin or none of the above. So what is false? So, cell wall has high lipid content. This is true. Mycolic acid form vexicot. This is also true. And the lake, the exotoxin and the endotoxin. Now, uh, Mycobacterium of particular importance is the presence of the long chain fatty acid called the mycolic acid, for which the mycobacteria are named, and the lipoarabinomannan, a lipid polysaccharide complex extending from the plasma membrane to the surface. So the mycobacteria have the mycolic acid, which is a characteristic for it, and lamb, that is a lipoarabinomannan, is present in the plasma membrane to the surface, and these elements give mycobacterial cell wall with high lipid content. So this is also true. So the lipid content of the mycobacteria is high due to what? The mycolic acid in the allium, and they forms a waxy cord that makes them hard and the hydrophobic. They do not produce the exotoxin and endotoxins, and disease process are thought to be the result of the due to the this delayed delayed type of hypersensitivity and cell mediated immunity, right? So due to the cell mediated and delayed type of hypersensitivity, the reaction is mainly present neither because of the toxins. The toxins are not, exotoxin and toxins are not present. Mycolic acid is present, LM is present in the cell wall extending from the plasma membrane to the surface, and the lipid content is high, giving the waxy cord appearance, right? So in Plasmodium virus, the vivax relapse is caused by sporozoites, schizont, hypnozoite, and the gametocyte. So very easy question. Relapse is caused due to relapse is caused due to what? Due to hypnozoites, right? Now hypnozoites in malaria, the RBC. Now these are some key points. That is, size of RBC increases in where? In the vivax. Infective agent is what? Sporozoite. And now for falciparum gametocyte are seen in the peripheral blood smears. Parasitemia is highest. It is the most virulent, and exoerythrocytic stage is absent. Multiple infections and splenic rupture is common. So important, exoerythrocytic is the stage is absent. Now this is a life cycle. Now the sporozoite is the infective. Now they are taken up by the mosquito salivary glands. They are present in the salivary glands of the mosquito, and they are released at the during the blood sucking by the mosquito, right? So they will either go to the liver, that is the exoerythrocytic, and it was absent where? It was absent in where? Exoerythrocytic. Where was it absent? It was absent in the falciparum, right? And either to the dormant stage, that is the hypnozoites, and that is for P, vivax, and ovale. Remember it. is present in which hypnozoid stage is present in which malaria species, that is the vivax and the ovale, right? So, and they will again will go to the erythrocytic cycle and form the gametocyte. So this is was it. That is the will not come to the life cycle because it will take the time. Will not be able to cover up the questions now. OPV can be used if vaccine while monitor is showing color of the outer circle is same as the inner square, color of the outer circle is darker than the inner square, and color of the outer circle is lighter than the inner square, or none of the above. What is true? OPV can be used if while monitor is showing what color of the outer circle is darker than the inner circle, right? So the square is lighter than the circle. That is the whisker, and this will be square. Right. So, that expiry date is not passed. If the square is lighter, then the expiry is not passed. Use the vaccine. If the square matches the color, then do not use the vaccine. And if this is darker, if the inner square is darker than the circle, then do not use the vaccine. Right. Skyzone and the late trophozoite stage of the Plasmodium falciparum is not seen. This is very important question. Is not seen in the peripheral blood smear because they are sequestered in the spleen or due to adherence of the capillary endothelium, and they are not seen in the peripheral blood due to the antigen antibody reaction and removal, and they are seen in the mosquito blood. So, what is true? What is true? It is due to adherence to the capillary endothelium. They are not seen in the peripheral blood. So, due to adherence to the capillary endothelium, right? Plasmodium only ring stage or the gametocytes are seen. Also, the exoerythrocytic cycle stage was also not present here. Only the ring stages and the gametocytes are seen. Skyzones and the late trophozoite stage are not seen because they make the parasites make the red cells sticky, so they tend to be retained in the deep capillary beds, except in the overwhelming fatal infections. So they are stick to the capillary endothelium. They are not released. Therefore, they are not seen. Now, which of the following is the most common systematic symptoms during migration of larval phase of helminthes like ankylostoma, strongyloids, and the ascaris? Is either asymptomatic pneumonitis, liver failure, or the larva migrans. So, what is the most common symptom? What is the most common symptoms? It is actually asymptomatic, right? Larvae of the Ascaris hookworm strongyloids migrate through the lung and the various tissues during their life cycle, and sometimes larvae appear to in larva migrants they appear to lose their way and wander around. It's generally seen when human infections occurs with non-human species of the nematodes, that is Ascaris. Pathological effects causing the allergic reaction and uh, hence, larvas in initial exposure usually asymptomatic except on very high larval load. Symptomatic visceral larva migrants is produced by infection with non-human nematodes. They cause local alveolar hemorrhage. Clinical pneumonia is seen only in the massive infection, hence mostly it is what? Asymptomatic. Now, a patient presented to the hospital with several severe hydrophobia. You suspect rabies, obtained corneal scraping from the patient. What test should be done on the specimen for the diagnosis of the rabies? Right? ओके। सो वैसे देखा तो सभी ठीक है, नेगरी बॉल से डिटेक्ट करेंगे एंटीबॉडीज टू रेबीज वाइजर, आरटीपीसीआर और इंटेंट इम्यूनोफ्लोरेसेंस, बट द मोस्ट करेक्ट वी हैव टू चेक, वी ऑलरेडी नो द पेशेंट इज हैविंग हाइड्रोफोबिया, ठीक है, एंड कॉर्न स्क्रैपिंग से वी सस्पेक्ट द रेबीज, राइट? सो वी हैव टू सी द मोस्ट हाईली सेंसिटिव टू चेक द टू द फाइनल डायग्नोसिस, सो वी डू द आरटीपीसीआर, ठीक है। डिटेक्शन ऑफ द रेबीज आरटीपीसीआर with genetic sequencing, highly sensitive and the specific, accurately identifies the rabies genome in the CSF, saliva samples and the scrapings and the urine. Distinguishing among rabies virus variants permits identification of the proper probable infection source. Right? Reverse transcription PCR testing. It is used to amplify the rabies virus genome from fixed or unfixed brain tissue or the saliva, and sequencing of the amplified protect allow identification of the infective virus strain. Now, these are what the Negri bodies, right? And they are eosinophilic inclusion bodies found in where? Found in the hippocampus. Mainly in the site is asked, they are mainly found in the Emmons horn of the hippocampus. Which of the following is an obligate intracellular pathogen? Coxilla, Listeria, Klebsiella, or Legionella? It's clear we should know what are the obligate intracellular pathogens and what are the examples. So, what is true that which of the following is an obligate intracellular pathogen? It is what? It is Coxilla, right? So, some examples that we have to remember for the obligate intracellular one is the Rickettsia, Mydia. These are the facultative, now obligate rickettsia, chlamydia, coxilla burnetii, and there are a few fungus that we read. Is a histoplasma capsulatum and the cryptococcus. They all were also the intracellular pathogens. Which of the following infections cause a non-centrally distributed rash? That is the epidemic typhus, measles, secondary syphilis, or the typhoid. So, which of the following cause a non-centrally distributed rash? So it is what? It is epidemic typhus. Now, इसका हमको पता होना चाहिए what is the centrifugal and the centripetal. Now, when we talk about the centrifugal, that is starts from the face or the trunk and it will move to the extremities. This is what? Centrifugal. Okay. When we talk about the centripetal, that is starts from the extremities and will move towards the trunk and the face. This is the centripetal. Okay. And example, epidemic cyphus is an example of the it is example of the centrifugal rash. Now, one is the epidemic typhus. The rash begins on the upper trunk on the 15th day and later becomes the generalized. Right. So this is a rash of the epidemic typhus, and we have to remember the centripetal and the centrifugal rash examples. First, we'll talk about the centripetal, that is mnemonic, that is a rad rash scare prevents very much. And for the centrifugal, that is primarily on the extremities, and the centrifugal, they start from where? They start from the face and trunk and moves to the extremities, right? So, mnemonic for the centrifugal rash is cars, right? So, and it can be remembered that you drive scars with hands and feet. So mainly they will start from the face and the trunk and will move to the extremities. Okay, easy to remember. Just remember one, that is centrifugal, and CAR stand for Coxella A virus, Rocky Mountain spotted fever, and the secondary syphilis. Okay, that is the CARS. Coxella A virus, Rocky Mountain spotted fever, and the secondary syphilis. Since we drive car with the hands and the feet, so easy to remember this. And another, rubella, roseola, scarlet fever, varicella virus, and the measles, they are centripetal rash. That is, they will start from the extremities and they are primary or central or truncal. This is what these are the measles rash, and this was what the centripetal rash. That is starting from the extremities to the trunk and to the face. Now, Pavlizumab is the humanized monoclonal antibody. Which of the following condition it has been improved for? The avian influenza, for the respiratory syncytial virus, or the Coxsackie virus. So what is the answer here? So it is what? Pavlizumab has been approved for respiratory syncytial virus. Now, pavlizumab is what mab, that is the monoclonal antibody, and it is used for the treatment of the respiratory syncytial infections and recommended for the high-risk infants at 24 months of age. Right now, a 15-year-old presented with the fever and the chills. For 3 days on examination, he found to have a delayed skin pinch type and dry oral mucosa. A peripheral blood smear revealed the following picture identify the pathogen involved. Okay, so the key presentation, that is the fever and the chills for the 3 days, and they were dry oral mucosa. Now, microscopy has been given. It's either Babesia, Plasmodium vivax, Falciparum, or the Salmonella type C. If you clearly see here, it is the ring form that is given, and here it is the banana form, or that is for the gametocyte. So where it is present in the Plasmodium falciparum, right? That is the ring form. So see here, that is the double ring form that is present in where, and the banana shaped gametocyte, and the double ring form in the erythrocyte that is present in the falciparum bacteria. Now, coming for the Babesia, it is transmitted by the ticks and invades the RBC and replicates. Clinical symptoms are similar, that is fever and the chills and the fatigue and renal failure. But we here see that the trophozoite is what? In the tetrad form. Trophozoite is what? In the tetrad form, right? And the vacuolated forms are also present. So tetrad forms and the vacuolated forms present in the Babesia, right? So this was about the Babesia and the Plasmodium falciparum. A sexually active male presented with warts on his penis as shown below. Which of these strain of HPV is most commonly of these lesions? That is HPV 1, 2, 3, 3, 5, 6, 11, or 16 or 18. Remember, the anogenital warts penis are seen in where? Seen in HPV 6 and 11, right? So HPV 6 and 11 surface is either smooth or rough, and penile genital warts, the usually 2 mm in diameter, often occurs in the groups. Now, it is a second type of penile lesion with keratotic plaques and slightly raised above the normal epithelium, as a rough, often pigmented surface. If you see, often a little pigmented, and the rough often pigmented. Now, velvet warts are the soft with white papules that either are sessile and have multiple fine finger-like projections. Now, when we talk about the HPV 6 and 11, it is mainly responsible for 90% of the anogenital warts, and the prevalence is mainly in the women, the 20 to 14, men in 25 to 29. Now, coming about the lesion where they found mainly, now HPV 1, 2, 3, and 7, their warts are present on the extremities, on the head, hence now HPV 6 and 11, showing the condyloma and the anogenital warts. HPV 16 and 18, they are be responsible for the cervical cancer with the malignant lesion, right? So when we talk about the HPV 16 and 18, they are the cancer causing, while the 6 and 11, that we saw HPV 6 and 11, they are mainly the non-cancer causing, and they are for the 90% of the anogenital. Remember, HPV 6 and 11, 90% of the anogenital warts are caused by them, while the HPV 16 and 18, they are causing the cancer causing type for the cervical cancer, vaginal, and the vulvar cancer. Right? When we talk about the condyloma anogenital wart that is caused by the HPV gut 6 and 11, now they are either single or multiple. We have seen they are dome shaped and the cauliflower shape, right? With fungating pedunculated plaque like smooth, and they are seen mainly the anogenital warts that is the seen mainly in HPV 6 and 11. Now moving to the next question. A 32-year-old slum dweller presented with complaints of the diarrhea and constipation with 2 kg weight loss for last 2 months, right? On examination, the patient had a dry tongue and the poor skin turgor. An endoscopic biopsy from the gut revealed the following microscopic appearance. Now, what is the most likely diagnosis? Now, one point is that he is a slum dweller and presenting with the diarrhea constipation with 2 kg weight loss. So the most important is the microscopy. The image is given here. If you can see now, what is the most likely diagnosis? Is what? It is the Giardia lamina giardiasis. Why? Because I don't know if you are able to see clearly here, the trophozoite form of the Giardia lamina is present. Now, they show that is the pear-shaped presence of the on the biopsy of the Giardia lamella trophozoite form, and they are having the equally sized nuclei. We have seen how does the Giardia lamella, and they are tightly bound to the villus enterocytes, right? If it is heavy infections, villus blunting with increased number of the intraepithelial lymphocytes and proper inflammatory influence, and clinical features asymptomatic carries to fulminant diarrhea. It may vary. In acute case, the incubation period 5 to 6 days and persist up to 1 to 3 days, and the abdominal pain, diarrhea, blanching, nausea, and the vomiting. Now, coming to the Giardia lamina, it is also called as the traveler's diarrhea, right? And the Giardiasis, also in Giardia intestinalis, now it is what? By the fecal oral fluid, that is why the contaminated water, food, and it is less common by the sexually transmitted. Now, cysts are the susceptible to drying, heating, or prolonged exposure to feces viable in cold water. Now, flagellated trophozoites, they remain in the small intestine. They are free living attached to mucosa and often present even in the severe cases. So the life cycle was easy. That was fecal oral route. We ingested the cyst form and it matured in the small intestine. The trophozoite in the cyst form, they are released where? In the feces. Now, given below is the histopathology of the liver biopsy of a patient with hemochromatosis. Which of the following stain has been used? That is Elsham stain, blue, Prussian blue stain, crystal violet, or the von Hossa. This stain, it is present. It is what? For the hematochromatosis, we are seeing that is to see the iron content. We are using which stain? That is the Prussian blue stain, right? So the we have to remember that Prussian blue, we see the iron, right? Von Cosa stain and alizarin stain, we see what? Calcium. Fontana that we are using for melanin, Fontana meson stain and Orcine, rhodamin that is for copper. Okay? So Prussian blue that we ask for the iron, von Cosa and alizarin that is can be remembered by mnemonic K, that is alizarin, von Cosa we are using for calcium. Okay? Fontana meson that is amphoram for melanin and Orcine that is for what? Copper. Now this is what? This is the von Cosa stain showing the calcium. This is Prussian blue stain giving the blue stain to the iron deposition. This is the von meson amphoram for the melanin. We have seen that is wherever melanin is present, it will appear as black and the nucleus as the red or the pink. Okay, so Fontana meson for the melanin, Prussian blue for the iron, and the von Casa and the alizarin for the copper, and Orcine for the copper, and the Cosa was for the calcium. Now, a 40-year-old HIV positive patient presented to the emergency with the fever, neck pain, and the vomiting. He ultimately died, and the appearance of the brain at the autopsy and the micrograph is shown to identify the most likely pathogen involved. Now, a section of the brain was also given in the examination, right? And this microscopy was given, so we have to identify that is responsible for causing the symptoms in HIV patient. What is the answer here? So what it is, you if you classical see the appearance, this is called the soap bubble appearance of what? Cryptococcus. And cryptococcus एक और था, ये क्या था? It was capsulated fungus. और क्या होता है ये? इंट्रासेलुलर होता है. ठीक है. So clinical features and the image suggest cryptococcal yeast infections. Clinical features in CNS in the involving the meninges, gelatinous fungus and maps show a expand perivascularly with gray matter producing the soap bubble lesion. This is very important to remember for the cryptococcus. Now, cryptococcus neoformis and the Getty. Now, it is what? Encapsulated, I told, and host inhales and disseminate to the CNS. It is a major opportunistic in the AIDS patient. Now, Cryptococcus meningitis and encephalitis, Cryptococcus neoformans associated with the immunocompromised, while Cryptococcus gutti is associated with the immunocompetent granuloma. This point is important. The Cryptococcus neoform is present associated with the immunocompromised person. Now, pulmonary infection is mostly asymptomatic, but pneumonia is present, infantry is present. Now, soap bubble lesion is very important to remember that they are present in the cryptococcus and they are what? They are capsulated. Now, this is the typical appearance of the soap bubble appearance of the cryptococcus. We have to remember that is the soap bubble abscesses are shown by the cryptococcus. Now, this is also same, that is they are showing the cryptococcosis, that is yeast-like organisms surrounded by the clear halo representing what? Why the halo is showing? This is the nucleus that is present inside, and this is what? This is the capsule with the H and E stain. Now, in the following gram stain specimen, identify the bacteria seen, that is the Streptococcus pneumoniae, Staphylococcus aureus, H. influenza, and the Neisseria gonorrhea. So first we have to identify it is what? The gram stain, it is what? The positive gram positive or the gram negative. Now the gram positive, how they appear? They appear purple due to the retain of the crystal violet color. So they are neither streptococcus neither the staphylococcus. So बचा क्या H इन्फ्लुएंजा या फिर निजीरिया. Now H इन्फ्लुएंजा तो क्या होता है? प्लियोमॉर्फिक शेप होता है. वो तो कोकोबैसिलस भी हो सकता है, बैसिलस भी हो सकता है. So H influenza has variable shape. But if you remember the Neisseria gonorrhea, right? They were what? They were diamorphic, है ना? और इसको अपने याद कैसे क्या था? They were what? Kidney shape. Neisseria gonorrhea is what? Kidney shape and the dimorphic bacteria, that is they are what? Kidney shape. जबकि beans shape क्या था? Neisseria meningitis. Now, Neisseria gonorrhea, they are pink colored cocci, mostly like Neisseria meningitis or Neisseria gonorrhea. Now, this is showing the gram positive or the gram negative. They are what? The gram negative and non-encapsulated and the kidney shaped are the Neisseria gonorrhea, while the bean shaped are the Neisseria meningococcus. And they are gram negative, that is alcohol lipid solvent dissolves outer lipopolysaccharide membrane of the cell wall and damage the peptidoglycan attached cytoplasmic membrane. Hence, the color is not retained. The following are image of the intestinal nematode. Which of these are true about it? Is transmitted to the percutaneous and the autoinoculation. Embryonated egg is the infectious state of this worm, and the adult form usually lives in the small intestine, or triclabendazole is the drug of the choice. So first, see which type of intestinal nematode it is, and which of the following is true about it. What is it? It is trichura. Okay, and they are not transmitted through percutaneous, they are transmitted to the fecal-oral route. And the infective stage is not it is not the embryonic stage, and the adult worm lives in the large intestine. So trichura is embryonated form is the there are mainly two main forms, that is embryonated form and the adult form. Now infectious stage that is transmitted is by the oral route and it is the adult. Now adult male forms they slender anterior end, that is they are having a slender anterior and thicker posterior end and hence appear buggy whip or the whip worm, and they lives where they are large intestinal nematode. Okay, and what is the life cycle? Egg is passed in the feces and the egg is infective after 3 weeks of incubation. So what was asked? It was which of the true, that is the true state of the. Now human acquires infection by eating the food and the contaminated with the infective egg, right? So infective stage is what? It is the egg stage. Embryonated egg stage is the infective stage and is transmitted by the oral food. Right? So moving to the next question, I guess this is the last question. That is, a patient with benign hypertrophy of the prostate was admitted in the hospital for the 3 weeks. He subsequently developed suspected catheter-associated urinary tract infection. The tip of the catheter was sent for the culture and was grown on the blood agar. After 24 hours, the blood agar shows the following appearance. What is the most likely causative agents of the UTI? E. coli, Klebsiella, Proteus mirabilis, or Pseudomonas. It's easy to identify by the image, which is what? This is what the swarming motility और swarming motility में किस में दिखती है? It is seen where in proteus, right? So it is what? Proteus. Now blood agar showing the concentric swarming is seen in proteus infections, and they are more active movement with the flagella resulting in swarming on the solid media. And what were the methods that we were using to decrease the swarming motility? That is adding agar, that is increasing the concentration of agar, or using the McConkey, or using the clad media, because they are having the salt and that is inhibiting the swarming motility, right? Now this is the swarming growth of the proteus on the blood agar. And now coming to the next question, which of the following trypanoma is seen with the silver pigmentation micrograph below? Leptospira interrogens, Trypanoma pallidum, Escherichia, or the Borrelia? That is, we are seeing the trypanoma by the silver pigmentation, and which uh, organism it is, which trypanoma it is. Now this is Leptospira because the hook shape appearance is present in the Leptospira. In the Trypanoma, it is the corkscrew appearance. Right, we'll see in further. And now, hook-like appearance in dark-field microscopy suggests to the Leptospira, and they are tightly coiled, thin, flexible spirochetes. They are actively motile, seen with the dark field, and they are what thin, having the thin axial filament and delicate membrane. In the dark field view, they appear only as a chain of the minute foci. So this is the silver stain of the Leptospira interrogens. Now, they are what obligate arrows and the characteristic hook shape appearance. We identified by characteristic hook shape appearance, just like a question mark, that is for the Leptospira, and by the silver implementation, we were seeing what Leptospira. This is the Trypanoma pallidum, as I told you, is the corkscrew appearance, motility that is seen again on the dark field microscope. This is what? This is Trypanoma pallidum. Now, a child presented with a complaint of severe itching over the web of the fingers more at the night. Examination revealed the burrows. What is the most probable diagnosis? Now, what is the most probable diagnosis? Tinea cruris, scabies, infantile eczema, or papular urticaria. That is severe itching, and that too on the web space of the fingers. And what is important point, that is at particularly at the night. And burrows, so these important point that is revealing pointing towards the scabies, right? So because the scabies show having the burrows, and mainly the web of the fingers are the main site for the children presenting with a severe itch. Now, a patient presented with the blisters as shown on the hand, feet, and mouth. Most probable causative organism was Coxsackie A, or Coxsackie B, EBV, or the CMV. Actually, this is what? Hand, foot, and mouth syndrome that is seen in what? Coxsackie A, right? Very important to remember this, that is hand, foot, and mouth disease, that is Coxsackie A, and it is painful red blisters on the throat, tongue, gums, cheeks, hands, and the feet, right? So this was it for today's session. Today's session was entirely the question and answer question, without covering much of the questions theory. Now, see you in next session tomorrow in tomorrow's class. Tomorrow's class will be also on the same. That is a rapid random division, random questions, and use my code, that is Muskan, to get 10% of the discount. And I hope everyone is doing well and safe at the home. Please be safe. Please be try to avoid this panics and the anxiety, because you will be shining well in the examination. Whatever prepared will be good, and do not worry. Have good sleep and good food. Whatever you done till now is what you did the best for preparation. So don't have the regret of any time just because few days are left, and whatever you read now will be coming in the exam. So just don't let your studies suffer for these rest of the days by going in anxiety or in this not so study mood type. So just study and just revise the most volatile subjects, patho, micro, PSM, and from where the volatile so many the volatile things comes, and we tend to forget the one liners and all. So please do revise the volatile subjects, and I hope the session was clear today. So see you in the next session. Have a good sleep and good night. See you tomorrow.